Hello, everyone. My name is Angela Ferguson, and I'm a family nurse practitioner here at Loyola Hospital. The title of my DNP project is Guidelines for the Care of Chronic Opioid Users with the Help of a Clinical Decision Support Tool. I co-authored with Dr. Fran Vlasses, Dr. Erin Mickelfelder, and Dr. Audrey Klopp. The background of my project includes opioids are currently the main cause of drug overdose deaths, leading to more than 67.8% in 2017. 1 in 5 adults received an opioid prescription in the last year, and nearly 33% received an opioid prescription in the last 2 years. 19.1 million of opioid prescriptions were written each month from 2012 to 2017. And most importantly, Loyola does not currently have an opioid guideline for the care of chronic opioid patients in the ambulatory setting. I started with a PICO question of, does the implementation of an opioid guideline, which includes a clinical decision support tool and the electronic health record for providers in a primary care urban clinic, lead to decreased opioid prescribing and increased use of a CDS tool and opioid protocol elements? I also looked to improve documentation, including opioid protocol elements. The project plan included that it was a quality improvement project. The participants were Loyola Family Medicine Department providers in 3 clinics. It established new opioid policy and created an EHR smart set consistent with newly created opioid policy during chronic pain office visits. Education was provided to family medicine providers via monthly department meetings, as well as videos distributed for providers not present during those meetings. The sampling technique, specific data was collected from the electronic health record from chronic non-cancer patients over 6 months. I took most of the data from the electronic health record and chart audits. The budget was minimal. It was printed material for the ORT and COMM tools. And I also made laminated copies of the new opioid policy for the clinicians. The timeline was 6 months. It was cut short due to COVID, and it was IRB exempt. Some of the implications for this project included decreasing opioid prescribing in a suburban family medicine department, better patient outcomes, improved knowledge among advanced practice nurses and their physician colleagues, and improved screening for opioid misuse with the opioid risk tool and the current opioid misuse measure tool. The results included pre-implementation opioid prescribing rate was 3.25% and decreased to 2.4% during post-implementation. You can see that in figure 1. The blue represents the pre-implementation numbers per month, and the orange represents the pre-implementation or the post-implementation, I'm sorry. Another thing it showed is that pre-implementation opioids over 90 morphine milligram equivalent was 0.1% rate pre-implementation and decreased to the 0.08% during post-implementation. That's figure 2. And in figure 3, you can see that pre-implementation opioid and benzodiazepines prescribed concurrently occurred at a 0.23% rate, and it decreased to a 0.20% rate during post-implementation. The conclusion is that the newly created opioid policy and EHR Smart Set appears to have a positive influence and reduction on overall opioid prescribes, opioids over 90 morphine milligram equivalent, and opioids prescribed concurrently with benzodiazepines. There would have been a greater correlation in in-person office visits continued. However, due to COVID, our visits went to virtual. And the data provided this data is provided in some of the first results observed when it comes to opioid prescribing and EHR smart sets with the combination of interventions included. Therefore, it's difficult to compare to other studies. A pre and post implementation survey was also collected to demonstrate the quality improvement interventions, improving prescribing behaviors and comfort. Part 1 survey results included responses from 13 providers. Most of the participants indicated either disagree or agree to questions 1 through 5, which included 1, I am comfortable with opioid prescribing in general. 2, I have knowledge of the 2016 CDC chronic opioid prescribing guidelines. 3, I have knowledge of the Illinois Federation of the State Board opioid prescribing. And 4, I'm comfortable with opioid prescribing documentation. However, nearly all, 12 out of 13, indicated agree or strongly agree to question 5, which was the new opioid guideline training I received was adequate to help me prescribe opioids for future chronic opioid uses. Only 11 providers responded to the post-survey due to maternity leave and inability to obtain response from one provider. Most providers indicated strongly agree in the post-survey compared to the pre-survey, and a few providers strongly disagreed compared to the pre-survey. Thank you again for listening to my DNP project.